Arabia. Good evening, everyone. I'm Dr. Samargandy from Saudi Arabia. Thank you so much for the invitation. I would like to talk today about the future interventional therapeutic itineraries for tricuspid valve. I have nothing to disclose. So, the tricuspid valve anatomy highlighting vulnerable structures, starting with the annulus, that it has a crescentic shape which is vulnerable to dilatation. And the septal leaflet is small in size and lack of papillary muscle, which create a coaptation vulnerability. But now the tricuspid valve is not forgotten and new lessons have been learned. No evidence, new strategies, and multiple therapeutic targets. We have started from medical therapy, going through the surgical repair or replacement, and ending up with CAVI solution to accommodate broad spectrum of different patients. The current landscape of tricuspid intervention goes in multiple domains, with the annuloplasty, coaptation enhancement, orthopedic replacement, or heterotropic replacement. And then there are the spaces or the spacer that we have to go through. Why do we need so many devices? Well, many patients cannot be treated with TEER or tricuspid valve replacement percutaneously, and anatomy-directed devices are important for long-term success and durability. Anatomy of subsets are challenging, sometimes like the large coaptation gaps, suboptimal imaging, the presence of a pacer meek or an ICD lead, and the RV dysfunction plus large annuli. And some patients have very difficult challenging subsets as in end-stage renal disease, poor imaging window, inability to tolerate oral anticoagulation, or they have a high risk for bleeding. And finally, of course, the challenging to do a transesophageal echo as in presence of varices, esophageal diseases, or difficult intubation. There are several options to treat tricuspid valve regurgitation, but one therapy is dominating the field, which is transcatheter edge-to-edge repair or TEER. And we have two players in the game, which is starting with the Abbott system, the TriClip system, with its first generation, which is multiple devices, and it can act sometime to some extent ability to optimize the grasping, and with its active closure, it might do as an annuloplasty sometimes. And then you have the Pascal system from the Edward Life Science, which is also a unique system, especially with elongation and nitinol and softness, that it can prevent some, entanglement in the dense cord of the tricuspid valve. Many trials have demonstrated the benefit and the improvement in the quality of life of these patients when it comes to successful end procedures. Anatomical screening selections are key to procedural success. You might use some 3D ICE imaging and maneuvers to help to reduce the procedural time, and it might improve the outcomes. There are some conflicting data between the RCT and real-world data on clinical and quality of life improvement, but this is only at 1-year follow-up. Improvement may be more significant beyond 1 year. Getting tricuspid regurgitation to less than 2+ will likely confer a clinical outcome. Second one, transcatheter annuloplasty repair. We have few toys, let's say, in this field with the Cardioband and the K-clip, but unfortunately still they are not very vast commercially available, and it's usually advantages. It goes more with atrial functional TR, standalone therapy, or combination to decrease the coaptation gap, and leaves a future option open still if you need to go again. And it doesn't need an anticoagulation, though that's a bonus for everyone. The problem is its availability and the lengthy procedure. Other tools are coming to the field, which is the CROI, the Coramaze, and the TriFlow, with bridging untreatable gaps and high ease of use with potentiality of quick procedure and spacer and central valve, as in the CROI. There is also the dual coaptation valve system with prosthetic valve with coaptation skirt and anchoring system which is adjustable catheter system, suspended coaptation element between the native leaflet, allowing them optimally positioned coaptation element. SVC stent anchor catheter while leaving the right heart untouched, ensuring no disruption of the normal cardiac function. They are still in the case study period, still not very available. And finally, you have also the transcatheter valve replacement or orthotropic replacement. So we have now the Evoke system, which is, CE marked, and it's started to be more available in the European countries, and now soon will be also in the Middle East. And then we have some of the other devices as in the Interpret, but still in the phases of trials. Why do we have so many valve replacement? Because the valve design originally actually it was for the mitral valve and being implanted in the tricuspid position. So by increasing the radial force, there will be a high pacemaker rate, and the tricuspid annulus is larger, so require large valve than the mitral. And then the IVC to tricuspid annulus offset requires dedicated delivery system or non-transfemoral access sometimes. The impact also of the stiff valve on the RV function, we have to take that in consideration. And don't forget, there is a large bore delivery system, there is a risk of permanent pacement, as we mentioned, and risk of valve thrombosis. So that's why you have vast majority of different devices, each encountering different kind of problem. So going back to the Evoke system, which is from the Edward Life Science, it's an internal frame, bovine pericardial leaflet, which is delivered through a 28 French transfemoral approach. And the beauty of it, it has three sizes, 44, 48, and 52. And it has 3 planes of motion, which allows steerability and precision in positioning. Going forward, we have also the Laplace TTVR system. Again, still we don't have it commercial or CE marked, but it is it's a simple transjugular delivery using 26 French delivery system, tissue-to-tissue contact near the AV node with a flexible outer core to minimize any TTVR-related conduction abnormality. It's a low-profile valve that minimizes the interaction with the subvalvular structure. And it has a medium and large size currently available to treat broad range of pathology and anatomies with parameter from 133 to 177. It's simple to deliver and it optimizes in the valve design, and it minimizes the conduction abnormality as we mentioned a while ago. There are potentials still with the TTVR, which is the anatomical eligibility. Because we know usually these cases depend on CT screening in order for you to make sure about the sizes and about eligibility. But unfortunately, there is like 50 to 60% high screen failure rate. And most of the time it is due to the annulus is too large or the lack of, having good, or the RV is small. And we know that most of the patients with a severe symptomatic TR are like a female dominancy, but they have a smaller RV, they have some big coaptation gap and big annulus. Second point is the anticoagulation need and duration. We don't have the sweet spot for that, and many patients have multiple comorbidities that may be preventing them from continuous or having lifelong anticoagulation, as in warfarin or in direct anticoagulant. Still, pacemaker is a risk, and you have to consider management strategy after the implanting of the valve, where to put the leads afterward. And then the final one is the acute RV afterload mismatch and prolonged hospital stay versus next day discharge in TEER cases, which is a very major issue. And this is where right heart cath and hemodynamic evaluation pre-procedure is very crucial in planning the strategic way of treatment. Finally, for those patients who are out of the spectrum of these, they go with the heterotropic valves, which is available now at the tric valve, and also recently the trilimium has been introduced, which is the sidestepping untreated tricuspid valve anatomy with a massive RA and RV dilatation, which is exclude basically whatever is going on in the RV or the tricuspid valve and just deal with the consequences of a TR. And Tricus study and Tricus Euro have shown a very dramatic improvement in the quality of life of the patient after the implantation. But they just, again, they will be requiring lifelong anticoagulation. And from personal experience, many of these patients have did tremendously great in terms of the quality of life improvement after the procedure. And it's the next day discharge. So you can see there is many factors that contribute to the choice of the therapy. It goes with anatomical criteria for the device selection, for patient going for tricuspid valve intervention, especially in the atrial secondary TR, because this is the most common one. And it goes either for TEER, ortho, HATU, or annuloplasty. And you just go whatever it's more favorable in your patient or less favorable for your patient. And with the last final slide, what are the future perspectives in terms of the transcatheter tricuspid valve repair or replacement? Well, the toolbox for the percutaneous treatment for tricuspid valve disease is rapidly expanding. Every person in this room have a device on his name. And secondly, the trend toward tailored device selection taking into consideration anatomical features and clinical status and patient risk profile is expected in the near future. So it's not going to be one size fits all. On the other hand, transcatheter tricuspid valve replacement lies behind the repair in terms of the procedural safety and major adverse cardiovascular event. But let's keep that in the point or in the side, because the orthotropic valve replacement has just started and the future is still bright ahead of us. In regard of the heterotropic transcatheter replacement, which is like an example in the tric valve, it may be considered an intervention aimed exclusively to reduce the congestion and its consequences. But to take it in the first step or the first line of treatment, still we are not there. And finally, I would like to thank everyone for attending this seminar and being here with us, and it's my great pleasure to be here. Thank you very much. Have a good day.
So, Dr. Samargandy, thank you very much for this beautiful overview of what's coming next. We will close this session for lack of time, but we do appreciate all the speakers